Hi class, and welcome to this video lecture on health services for special populations, chapter 11. So in this video, I'll briefly be going over a number of concepts found in this chapter, but I do want to make sure that you're aware that you are responsible for going through the PowerPoint presentation in its entirety, as well as reading the full chapter. My aim is just to briefly go over some of the main concepts, but I won't be going into too much detail. All right, so let's get started. So first, some of the learning objectives. So in this chapter, once you've grasped the information from this chapter, you should be able to describe population groups facing greater challenges and barriers in accessing healthcare services, identifying racial and ethnic disparities in health status. You should be able to discuss the health concerns of U.S. children and health services available to them, to discuss health concerns of U.S. women and health services available to them. Describe rural health challenges. A lot of this has to do with access to healthcare services and measures taken to improve rural populations' access to care in rural populations. Describe the characteristics and health concerns of the homeless populations and migrant workers. To describe the U.S. mental health system, summarize the AIDS epidemic in the U.S., the population groups affected by it, and the services available to patients with HIV and AIDS, and identify the benefits of the Affordable Care Act for certain vulnerable groups. So let's get started. First, I'm going to jump to slide 7. But before I jump to the conceptual framework of vulnerability, I would like to just quickly go through the terms used in this chapter. So terms you'll hear or you'll read when you're going through the chapter include underserved, medically disadvantaged, underprivileged, and American underclasses. Now, the different population groups we address in this chapter include racial and ethnic minorities, uninsured children, women, rural area residents, homeless, mentally ill, chronically ill, disabled, and HIV/AIDS. All right, so let's now go to slide 7. And here we are on the conceptual framework of vulnerability. So this framework calls for attention to the convergence of vulnerability attributes. People who experience a combination of risk factors are likely more vulnerable and therefore ought to be prioritized by policy and intervention initiatives. So the framework also suggests that public policy and programs must address several risk factors at the same time rather than treating each risk factor separately and in isolation. The later practice is still more common in the U.S., which results in both inefficient use of resources and ineffective assistance to the vulnerable populations. Now, when we're using the concept of vulnerability, we are talking about, or it refers to, the likelihood of experiencing poor health or illness. So here are the three main components, right? You have your predisposing factors, you have your enabling factors, and the need characteristics at the individual and ecological level. All these kind of place this population at an increased level of vulnerability when it comes to illness. And really, when you think of this framework, it's like we're going back to the concept of social determinants of health and how there are so many factors that impact one's health status. So I'm going to jump to slide 10. Really quick, here's the framework. We have the ecological factors looking at predisposing, enabling, and need characteristics. And then on the individual level, ultimately impact one's vulnerability and ultimately impacting their access to care, quality of care, which again affects their health status, be it physical, mental, or social. So really quick, when we're talking about predisposing characteristics, we're talking about racial, ethnic characteristics, gender and age, geographic location, enabling characteristics, insurance status. Are you uninsured or do you have insurance? Homelessness, and need characteristics like mental health, chronic illness, HIV/AIDS. All right, now we're going to jump to slide 12, covering racial and ethnic minorities. So there are four main racial, ethnic minority categories, which include Black Americans, Hispanic Americans, Native Americans, and Asian Americans. Now, Hispanic Americans include Mexicans, Puerto Ricans, Central or South Americans, Cubans, and persons from other Spanish cultures or origins. Native Americans include American Indians and Alaska Natives. Asian Americans include anyone whose origin is from the Far East, Southeast Asia, or the Pacific Islands. Now here we have the census, US Census from 2015, just giving you an idea of the percentage of each category we just went through. Now, one thing you'll notice is that there are health disparities among different minority groups. Minorities are more likely to be economically disadvantaged than whites, so they fall behind in health status despite progress made during the past few decades. So Blacks in particular, compared to whites, have shorter life expectancies, higher age-adjusted death rates for leading causes of death. They have higher age-adjusted maternal mortality rates, and higher infant, neonatal, and post-neonatal mortality rates. So Blacks are more likely to report fair or poor health status than whites. So in terms of behavioral risks, Black males are more likely to smoke cigarettes than white males, and Blacks have higher serum cholesterol levels from whites or than whites. So that just kind of gives you a little background information on the health disparities that impact us here in the US. So like in this graph right here, we're looking at US live births weighing less than 2,500 grams by mother's detailed race. So you look at all races, and here we have the different years. This is a cumulative kind of average. Then we have whites for those years. You have Blacks. Here are AAs or here are American Indians, and then here are Asian Americans or Pacific Islanders or AAs. And then last are of Hispanic origin. And this is looking at years between 1990 going all the way to 2014, just to kind of give you an idea of what I'm talking about when we're talking about these health disparities. Now on the next slide, which is slide 14, you will find a link to a video that just discusses health disparities looking at socioeconomic status and how income impacts that disparity in health status. Now, compared to Blacks, I just want to speak a little about Asian Americans. Compared to Blacks, Hispanics, and Native Americans, we have Asian Americans or Pacific Islanders. They're grouped together that have relatively small numbers. However, they constitute one of the fastest growing minorities in the US. So in education, income, and health, they actually form a bipolar distribution. Their median family income tends to be higher, but a higher percentage also live in poverty than the total population. So, all right, so jumping to slide 15, really quick. Low birth weight, again, is most common among Black Americans. White adults tend to drink more alcohol compared to other racial and ethnic groups. And here are just some stats from the chapter. Mammographies used for women 40 years and older tend to be greatest among white females and lowest among Hispanics. I would like to point out that from what I've read, and the prediction has been that in years 2042 to 2050, in certain geographic areas in the US, the majority populations will be Hispanic and Black and other non-majority groups. And whites will be the minority group. So it is important to kind of keep in your mind while you're looking at these different health disparities that there is this term of emerging majority. And really, this term really just describes this inevitable change taking place in American society based on these predictions. And I just remember I had taught a health disparities course not too long ago. And yeah, the prediction was for the years of 2042 to 2050 that these changes will be, these changes are currently happening and they'll be in place by then. All right, now jumping to slide 19. Black Americans are more likely to be economically disadvantaged than whites. They also fall behind in health status despite progress made during the past few decades. Blacks have shorter life expectancies than whites. They actually have the shortest life expectancy in comparison to all other groups. And this is largely associated to socioeconomic status, access to care, and other factors such as diet, opportunities available for exercise, access to necessary treatment or preventative measures, and community environmental concerns largely stemming from economic and environmental and social injustice. So that kind of gives you a gist of what is causing this health status gap that we're observing here in the US. And last, we're going to jump to Hispanic Americans. The Hispanic segment of the US population is growing at a significantly faster rate than other population segments. Hispanic Americans are also one of the youngest groups in the US. They tend to have relatively low education levels and higher unemployment rates than non-Hispanic whites. They're also more likely to be employed in semi-skilled, non-professional occupations. Actually, most of my research has been focused on Hispanics here in South Florida, but I always focused more on Hispanic groups that were underserved during my doctoral studies, and actually during my postdoc. My focus was on migrant farm workers, specifically in Immokalee. We also studied for a short time migrant farm workers in Homestead. And I met some amazing people. And one of the things that, we learned, being that this group tends to be kind of like an invisible community, you can say, is at least our study participants, which for the Immokalee study hit about, I want to say about 500. It was about it was actually like 442 if I'm not mistaken. And with the Homestead study, we hit about 243. With Homestead, it was focusing more on injection drug use among that population. And with Immokalee, we kind of really try to understand the social factors or those social determinants of health that were impacting the health of these migrant farm workers. And a lot of this was definitely evident in my research. The average educational level for the study participants that I had was about 7th grade. I think about 92% of my participants were undocumented. So just to kind of give you a gist, most of them, their families were abroad in other countries. We had a mix of different people from different Hispanic countries, included Mexico. We had Puerto Rico, even though it's part of the US, South America. And another big issue was level of social support, how that impacted their mental health, the concept of loneliness and how it impacted their well-being and their physical health. So it was just, I learned a lot those years when that project was running, and of course that's a different segment, which we're going to, segment of the population that we'll be addressing later on in this video lecture. But literally, I would say 90% of my migrant farm worker population or sample was of Hispanic origin. And so I kind of saw all this, my data kind of illustrated exactly what we're covering here. I just thought I would add that in. Now I'm going to be jumping to children. So I'm going to be going to slide 30. I know that was kind of like an abrupt transition. I could go on speaking about the, that research study and the, a couple of publications that I got out of it, and what information I learned forever. So let's continue on here. So the health concerns of children include lack of insurance, vaccinations, delayed access to medical care, and unavailability of sick child care or lack of leave benefits for working parents. So here we have 30% covered under Medicaid, 60% covered under private insurance. Remember, we have Medicaid, we have the CHIP program, and these are focused on providing insurance for those children that are uninsured. And even with that in place, we have a lot of children that are still uninsured. We're looking at about 5 to 20% of children that have disabilities, and they are either 18 or under. Now I'm going to go to slide 33. So among the unique characteristics of childhood that have important implications for health system design are children's developmental vulnerability, dependency, and differential patterns of morbidity and mortality. Developmental vulnerability refers to the rapid and cumulative physical and emotional changes that characterize childhood and the potential impact that illness, injury, or disruptive family and social circumstances can actually have on that child's life course trajectory. Children have complex and changing dependency relationships that influence their development and affect their utilization of health services. Children are dependent on their parents or other caregivers to recognize and respond to their health needs, organize their care and authorize treatment, and comply with recommended treatment regimens. So children increasingly are affected by a broad and complex array of conditions termed new morbidities. The new morbidities include drug and alcohol use, family and neighborhood violence, emotional disorders, and learning problems from which older generations do not suffer. So these new morbidities originate in complex family or socioeconomic conditions rather than exclusively from biological factors. Now, to sustain those positive outcomes, the new morbidities require a continuum of comprehensive services that include multidisciplinary assessment, treatment, and rehabilitation, as well as community-based prevention strategies. So now we're on slide 35, which I'm going to jump right over, since I already went over these this information. And here we are on slide 35. So healthcare for children, it's kind of compiled of these disconnected programs. So U.S. characterizes children's healthcare into three sectors. So the three sections are personal, medical, and preventative health services. That's one. Second one is population-based community health services. And the third is health-related support services. So when we're talking about personal, medical, and preventative services, we're really talking about those services that are generally delivered in private and public medical offices, hospitals, and laboratories. Now on slide 36, we jump to population-based community health services. And these provide services such as, again, immunization delivery, and monitoring programs, lead screenings, child abuse and neglect prevention, case management and referral programs for children with chronic diseases, and those requiring early interventions, and also monitoring programs for infants at risk for developmental disabilities. And again, the third section is health-related support services. And examples of this include nutrition education, early intervention, rehabilitation, and family support programs. So next, we're going to be covering the topic of gender differences and health outcomes. So the link found on the following slide actually kind of highlights this concept, if there are gender differences, and do they impact health outcomes. And I'm gonna actually pass slide 37 with that link and jump to slide 38 covering women. So women suffer greater morbidity and poorer health outcomes and have a higher prevalence of certain health problems than men over the course of their lifetimes. Women also develop more acute and chronic illnesses, resulting in a greater number of short and long-term disabilities than do men of comparable age. So even after reproductive problems are controlled for, women's health problems limit their activities 25% more days per year than do men. So women are bedridden 35% more days than men each year due to infectious or parasitic diseases, respiratory diseases, digestive system conditions, injuries, and other acute conditions. So in all illnesses, differences arise not only in the onset of the progression of illnesses, but also in the research, prevention, treatment, and education necessary to address these physical and mental disorders in women of all ages and across all racial ethnic groups. So with this being said, this will lead us to really the role of the Office on Women's Health. What does it do? Why is it there? Well, obviously we know, we've already went over kind of the poorer health outcomes that women tend to have. And now we're going to be jumping to slide, we are here, slide 48. The Public Health Services Office on Women's Health really is dedicated to the achievement of a series of specific goals that span the spectrum of disease and disability. So these goals really range across the life cycle and address cultural and ethnic differences among women. So the OWH stimulates, coordinates, and implements a comprehensive women's health agenda on research, service delivery, education across the agencies of the Public Health Service. So this includes the NIH, CDC, FDA, the Health Resources and Service Administration, the Agency for Health Research Quality, and the Substance Abuse Mental Health Service Administration, and even the Indian Health Service. And the Office of Women's Health also serves as a link across the country's public health system regions and with other governmental agencies. And this actually includes the Department of Defense, Department of Veterans Affairs, Central Intelligence Agency, Environmental Protection Agency, and even the National Aeronautic and Space Administration. So the Office of Women's Health is responsible for implementing the National Action Plan on Breast Cancer, which is a major public-private partnership dedicated to improving the diagnosis, treatment, and prevention of breast cancer through research, service delivery, and education. So it places particular emphasis on prevention of physical and sexual abuse of women, and even works to implement important protections for women against violence and abuse. Now, the next topic I want to jump to is rural health. I know I spoke a little about migrant farm workers, and we're going to go into the rural health sector now. And I'm going to be jumping to slide 52. And really quick, so what are some of the challenges that rural health tends to face? So they tend to have poor access due to poverty, long distances, topography, weather, and the availability of healthcare and transportation. So these poor economic conditions and lack of healthcare professionals in rural settings and the low population density really make it difficult for communities to attract physicians and managed care. So that is another contributor of the challenge in accessing healthcare. So as a result, you have rural populations that face greater barriers in access to care than urban populations. Now, there are various measures that have been taken to really improve access to care in rural America, and this leads us to the next slide. And this includes the promotion of the National Health Service Corps, the designation of health professional shortage areas and medically underserved areas, and the development of community and migrant health centers, and the enactment of the Rural Health Clinics Act. And the Rural Health Clinics Act really intended to increase access to primary care services for patients in rural communities. Now, the next slide, there is a link to a video. If for some reason it's not working or any of the links aren't working, you can definitely let me know. But there are also videos that I've included in the module in which this chapter is assigned that go along with the information presented here. So in the following slides, you will find more information on these different measures that have improved the access to care in rural communities. And what I'm going to do is I'm going to jump to the slide on migrant workers really quick and just tell you a little about migrant workers who are farm workers a lot of the time, who travel long distances from their primary residence or lack of primary residence entirely, either due seasonal crop changes or work availability. One thing I did notice with my research is the migrant workers that we worked with kind of had this migrational pattern. So we had to kind of spread out our follow-up periods in 6-month segments because depending on the season, like with immokalee, it's a major, the main crop is tomatoes. So once that season passes, they tend to migrate to another area and then they will return usually about 6 months later. So I thought that was very interesting. But their primary residence really entirely usually is based on those seasonal crop changes. And it's estimated that between 1 and 3 million, that there are between 1 and 3 million migrant farm workers that actually leave their homes again to plant, cultivate, harvest, and pack their fruits. And they come from different countries. As I said, my study, the one done in immokalee, was about 90% Hispanic. And of course, the countries those that were Hispanic came from were a mix of different Spanish-speaking countries. And then in Homestead, it was focused on the Hispanic community. So that was, with the Homestead sample, that was one of the criteria. But the next slides cover the different health centers that are funded by the US government to assist in helping those migrant workers that tend to be medically underserved. And then I'm going to jump to the topic of the homeless population. So I'll be jumping to slide 72. Now, the homeless population, again, consists of about 43% single male, about 17% single women. Families are about 39% of the homeless population. And there are about 40% of all the homeless men that are war veterans. So the economic picture of homeless persons, it tends to be very dismal. Almost half have not graduated from high school. And they, on average, have been unemployed for about 4 years. Only 26% have health insurance. And the shortage of adequate low-income housing is really the major precipitating factor for homelessness. So you have unemployment, personal or family life crises, increases in rent out of proportion, maybe due to inflation, reduction of public benefits that can also directly result in the loss of a home. The homeless, both adults and children, tend to have a higher prevalence of untreated acute and chronic medical, mental health, and substance abuse problems. So the state of being homeless produces risk factors that would otherwise not be incurred. And these risk factors include excessive use of alcohol, drugs, cigarettes, sleeping in an upright position, which tends to result in negative health outcomes, extensive walking in poorly fitting shoes, inadequate nutrition. So there are a number of factors that make this specific population at greater risk of negative health outcomes. And due to barriers to healthcare services, and due to barriers to having access to kind of outpatient services and those preventative services, the homeless population tend to have high hospitalization rates, and of course, using the ER as their go-to when health is an issue. Next, I'm going to briefly cover mental health and mental health services here in the US. So I'm going to be jumping to slide 78. 1 in 4 Americans have a mental health disorder in any given year, and it tends to be higher among women and individuals in the ages of 18 and 25. So now, the most common mental disorders are phobias, substance abuse, alcohol and drug dependence, and affective disorders. The major mental health professionals that address these mental health illnesses include psychiatrists, psychologists, social workers, nurses, counselors, and therapists. And when it comes to the mental health services provided here in the US, mental health services are provided through public, primarily for patients without insurance, and private resources. Again, those are for patients with insurance in both inpatient and outpatient facilities. So this includes state and county mental hospitals, private psychiatric hospitals, non-federal general hospital psychiatric services, Department of Veteran Affairs psychiatric services. There are also residential treatment centers and even freestanding psychiatric outpatient clinics. Now, managed care has become increasingly common in mental health. Insurers are now contracting for a limited scope of mental health benefits for enrollees as part of a more comprehensive healthcare package. Psychiatrists and other mental health providers are also contracting with insurers, employers, and managed care plans to provide mental health services for enrolled populations, often based on capitation payments. So the ability of managed care plans to provide comprehensive services and to meet the full range of patient needs, given the constraints of these contracts, is an open question at the present time. Now, the next topic I wanted to briefly cover is the topic of HIV and AIDS. So I'm going to be jumping to slide 90. slide 91. And we're going to talk a little about HIV and AIDS. Now, HIV, which is actually the acronym for human immunodeficiency virus, this virus infects the immune system by attaching to the surface of CD4 T cells. Now, this attachment prevents the immune cells from being able to attach to invading microorganisms, again, creating this deficiency in your immune system and making you susceptible to other illnesses. Now, initially, this attack may not cause much change in the body. So most people tend to be asymptomatic, meaning that they don't have symptoms. Others whose immune system is newly attacked by HIV may experience kind of flu-like sickness. And there have been some reports of pain in areas following, different areas of the body following the infection of HIV. Now, this once was an incurable viral infection, but there are now antiretroviral drugs that really prolong one's period of time in this HIV stage, where HIV and AIDS is slowly shifting or has shifted more as a chronic condition rather than this terminal illness, and because it is fatal if it is not treated. But if you are being treated with antiretroviral drugs, it will prolong that time for many, many years. So if you're not treated for HIV, or you decide not to take those antiretroviral drugs, which most people do, this leads to the acquired immune deficiency syndrome, which is full-blown AIDS, and it's basically the late stage of an untreated HIV infection. So at this point, the immune system has been fully attacked and is no longer able to protect the body from invading microbes. So in this stage, those experiencing or have gotten to that stage of full AIDS tend to get sick more often. Short-term sicknesses such as colds last longer. Bruising and injury occur very easily. Sores and other bodily injuries take longer to heal. They have this high likelihood of pneumonia and the stage of AIDS is where the infection is no longer treatable. And AIDS in itself does not kill the person, but the instability of the body to defend itself and leaves it vulnerable to infections that it cannot fight is what makes AIDS fatal. So many of you are probably aware of the mode of transmission of this infection. It's really spread only in certain body fluids from a person who has HIV to someone that doesn't. And these fluids include blood, semen, pre-seminal fluids, rectal fluids, vaginal fluids, and even breast milk. But now with breastfeeding, of course, if you are taking a medication and you are being observed and monitored by a physician, the risk of transmitting the infection from mother to child is actually reduced, is greatly reduced. Now I'm going to jump to slide 93. I do want to point out that here 1 in 5 of those infected tend to be unaware. And of course, if someone had unprotected sex, there's a 6-month window where it may not be detected. So usually if you're aware that you've engaged in a high-risk sexual encounter, you should get tested and then test one more time 6 months later just to confirm that you are not HIV positive. There are more than 1.1 million people living in the US with HIV/AIDS. And the highest percentage of new HIV diagnosis and prevalence rates actually is among the Black minority group. So when we're looking at incidence rates for HIV among Blacks, they tend to be 8 times higher than white rates, and more than twice that of Latinos. With that being said, overall, there has been this encouraging trend of a decline in incidence rates of HIV, specifically among Blacks and especially among women. And that brings me to the end of this video lecture. Please make sure to review this PowerPoint presentation in its entirety. I didn't get to go through all the slides because this lecture will get too long, but I have included a lot of detail in my slides to really help you understand the content. Please go through the PowerPoint presentation in its entirety, as well as reading the chapter. If you have any questions, never hesitate to reach out. Best of luck and take care.